GABI-R is a real-world registry, which was mainly performed in Germany and Austria. And the intention was to know more about the bioresorbable scaffold in a clinical setup, because most of the randomized trials excluded patients with certain or specific coronary morphologies. And for that reason, we want to include an all-comer cohort in GABI-R to show what is the efficacy and safety of the bioresorbable scaffold. We want to look in an all-comers cohort, which means that we want not to exclude certain patient group. For that reason, it was left to the physician discretion which patients could enroll in this registry. But as I said before, we want to have every patient in which an BVS was included in this registry. After inclusion of more than 3,000 patients, in total we include 3,326 patients with common risk factor, we could show that the BVS has an interesting low TLF, which means target lesion failure. The target lesion failure is a combined endpoint of cardiac death, myocardial infarction, and target vessel revascularization. And if you look at the 2 years follow-up, which was completed in more than 90% of patients, we could show that the TLF was not more than 6.4%. However, as the other registry also could show, and as we know from the randomized trials, we had an increased rate of scaffold thrombosis. The rate of scaffold thrombosis was 2.7% after 2 years. If you look now into the time points of occurrence of the scaffold thrombosis, we could see that the most scaffold thrombosis occurred within the first 30 days. So that reflects the fact that maybe there is a learning curve in terms of implantation process. And that's what we learned from GABI-R, that we should be very careful during the implantation process. So we should predilate the lesion very well. We should size the lesion properly. And after that, we should have a post-dilation not more than 0.5 millimeter than the scaffold device. And if we do so, we can reduce the scaffold thrombosis rate overall. The 2 years results could show that we have an overall very low clinical MACE rate. If we compare the MACE rate to an DS registry, we could see that the clinical outcome is not that high and not higher as we know it from the drug-eluting stent registry. However, a small or a problem remain, which means that we have this problem of scaffold thrombosis, which is not only maybe a problem with the implantation process, but also in the long-term run, that we maybe have problems in terms of scaffold architecture, so that we need second-generation devices to overcome this problem in the long-term run. But this is a very challenging question, and I guess that we should stay on improving this device technology. Of course, we have learned in the past that we should not use the bioresorbable scaffold technology for certain lesions, like calcified lesion, like bifurcation or ostial lesions, and that we have to use a specific implantation protocol. And if we do so, we can reduce the maze rate tremendously. However, we have this problem of the stent or strut thickness, which means that we have a doubled stent thickness in comparison to the drug-eluting stent technology. And for that reason, we should further develop second generation devices to overcome these problems, and finally to have a more appropriate device, which means that we can reduce also the scaffold thrombosis, which is actually from the registry and also from the randomized trials too high.